Good morning, everyone. My name is Bing Han. Welcome back to my Dermpath lecture number 3. Initially, the plan was to do this lecture in March. However, due to the busy schedule in March, especially with the RICE exam, we decided to push it to early April. But for consistency, I still put March here, just FYI. We have lots of things to cover today, so I will just get started. And this is just a quick reminder of what we have done in the past. We covered the benign and malignant epithelial neoplasm, soft tissue neoplasm, and melanocytic neoplasm. And from March, we will start our non-neoplastic topics. And in March, we will be talking about the cysts, infection, and panniculitis. What is a cyst? Cyst usually means it's a bump underneath the skin with a cyst structure composed of cyst wall and cyst content. It is usually a benign thing, but sometimes a long-lasting cyst, they can have malignant transformation. But that is not covered today. Let's just talk about the regular cyst. In order to have a better understanding about the different types of cysts, we need to know the structure of our pilosebaceous unit. As the picture shown on the right, you can see there are 3 portions, including the infundibulum part, isthmus part, and the stem. The picture on the left is using a cartoon to demonstrate the different portion. And you can see if the cyst is derived from the follicular infundibulum portion, the cyst is most likely to be an epidermoid cyst, but also including some other part of the cyst, including the vellus hair cyst and the pigmented follicular cyst, and the medium as well. If the cyst is derived from the lower portion, such as from the isthmus and the inferior portion junction, more specifically, the cyst has the outer root sheath differentiation. We are dealing with a tricholemmal cyst or pilar cyst, which is the same thing. And if the cyst is derived from the sebaceous duct, which is here, we have the citiatocystoma. The next picture has a better histologic demonstration. This is a hair follicle, but I put it horizontally to have a better demonstration. If you look at this portion, which is the infundibular portion, you can see there is presence of granular layer. If you go down to the isthmus portion, there is loss of granular layer. If you look at the duct between the sebaceous duct and the hair follicle, you can see there is a pink cuticle with a shark tooth wavy morphology. And because of that, we have different types of cyst. If the cyst derived from this area, we call that follicular cyst. If we have a cyst derived from this area, we have a pilar cyst. If we have a cyst derived from the duct of the sebaceous gland, we call steatocystoma. So let's talk about each individually. And in general, when we talk about the cyst, we subdivide the different types of cyst based on 2 things. First is what type of wall it is. Second, what is the cystic content? For example, this one, which is the most common epidermal inclusion cyst, EIC, or if Dr. Lala is here, he will call this follicular cyst infundibular type, which is more accurate. And the cystic content, let's talk about cystic wall. The cyst wall is, since it's derived from the infundibular portion, we know there should be a granular layer. And the cystic content is a laminated flaky keratin. You have already grossed many of this. I know you have no problem identifying this. But just pay attention, what is not here? The things should not be here is the adnexal structure. If there is adnexal structure, it should not be an epidermal inclusion cyst. It should be something else. We will talk about that later. And here is a demonstration of the granular layer here and the flaky keratin. You are very familiar, I'm sure. Next is also a very common type of cyst, which is the pilar cyst, or if Dr. Lala is here, he will call this more accurately as follicular cyst tricholemmal type. This is derived from the isthmus portion, which is the outer root sheath of the hair follicle. And we know there is no granular layer, and that's why the cyst wall is without granular layer, but the keratin is dense, as the picture showing here. Very pink without granular layer, and the keratin is very dense. That is the feature of the pilar cyst. Those two we should be very, very familiar with. And next one is not a very common type of cyst, which is a dermoid cyst. Don't be confused the dermoid cyst with epidermoid cyst. There is a big difference. And we have the ovarian dermoid cyst. That is something totally different. Don't be confused. The dermoid cyst usually happens in the younger population, usually infant, and the common location is the lateral eyebrow. And the reason for this dermoid cyst is because of the faulty development along the embryonic fusion line. So here is the embryology. You can see there should be a fusion from the left to right. And when there is a problem, there is a folding issue, there is a dermoid cyst happens. And the feature of dermoid cyst, let's talk about the wall. It has the same wall of the epidermoid cyst, which has the granular layer. But there is something different, which is the cystic content, which not only includes the keratin, laminated flaky keratin, but also it has hair shafts. And more importantly, it has adnexal structure present. When I say adnexal, not only the sebaceous unit, but also the hair follicle. So next picture is showing the structure of a dermoid cyst. And you can see the dermoid cyst has the same nature of the flaky keratin, and also there is presence of the granular layer and abundant adnexal structure. So this is the dermoid cyst. And next one is a very interesting type of cyst called steatocystoma. And it usually happens on the trunk, neck, and head of adult people. And it can be familial, and sometimes you can see the patient with multiple steatocystoma. And if you cut into one of the cysts, you will see the yellowish, lipid, oily material, like the toothpaste, like this. And since it's a very oily, during the processing, the cyst content usually just washed away. And the epithelium, as we mentioned in the structure of the hair follicle, they have the eosinophilic cuticles, which resemble the shark teeth. And here is the demonstration of the cyst wall and empty cyst content, and with the red shark tooth cuticle. So this is a very characteristic component, the sebaceous gland. Next type of cyst usually is a biopsy from either dermatology or ophthalmologist. And clinically, they can see there is like a sac of clear water in the eyelid region. And it looks translucent or sometimes the bluish. And that's the common site in the eyelid. When they cut the thing out and send for pathology, since it's a clear fluid, usually just get lost. When we receive, we only have the empty space. And even we can process it intact, the fluid will be washed away during the process. Here is the low power picture showing there is a open space. And again, we divide the different types of cyst based on the cyst wall and the content. The content is just a clear sweat. And what is the cyst lining? The cyst lining is derived from the sweat duct. And the sweat duct usually has a low cuboidal appearance with snouts, which is a resemblance of the apocrine gland. Some people will divide the hydrocystoma into the apocrine versus acrine, but it doesn't matter. Clinically, there is no difference, and the treatment is the same. Next type of cyst is not very commonly seen. It usually in the midline of the neck of a child or young adults. And when the person swallows, the cystic structure will move along the swelling. And if you sample the lesion, you will see the cyst lining has the columnar, cuboidal, or stratified squamous lining. But the striking thing is not what is the component of the cyst wall, but what is adjacent to the cyst wall. And the adjacent tissue is the thyroid follicle, like here. So that is the key point of this seroglossal duct cyst. Next type of cyst is also not very common, and it's called a branchial cleft cyst. And the common location including the preauricular area from the jaw as well as the lateral neck, as which we see here there is a little cyst in this location. And the cyst content usually is the laminated keratin, and we can see the epithelium is the squamous epithelium, and also there is presence of the granular layer. But what is more characteristic of this branchial cleft cyst is there should be abundant lymphoid follicle even with the germinal center formation. So whenever you see there is a lymphoid follicle associated with the cyst, think about this branchial cleft cyst, especially when it is at the lateral portion of the young person. Okay, so that concludes our portion of the cyst. But it's better to put everything side by side so you have a better understanding and you can organize your thoughts better. So here is the quick summary of the different skin cysts. And again, we use different types of wall, different types of cyst content, and what is out of the cyst. We use those three features to categorize different types of cyst. Epidermoid cyst, we know it very well. The wall has granular layer, it has flaky keratin, it does not have out of cyst material. Pilar cyst, we have no granular layer, we have very dense keratin, we have no out of cyst material. In the dermoid cyst, we have granular layer, flaky keratin, which is the same as the epidermoid cyst, but it has pilospacious unit. Steatocystoma, key feature, shark teeth, and it usually is empty because it is oily material washed away by the processing. Hydrocystoma, cuboidal cyst wall, and the content is sweat. Seroglossal, the key feature is the thyroid follicle. Branchial cleft cyst, key feature is the lymphoid aggregate. When you have those knowledge, you will have no problem diagnosing the most common types of cyst. Okay, that concludes our cyst portion. Let's move on to the skin infections. In the infection portion, I will focus more on the fungal infection and have a little bit on the parasite as well as the viral infection. The first fungal infection is tinea, which is also the most common type of fungal infection in human skin. From the histologic picture shown here, you can see in the stratum corneum there are many hyphae form of the fungus inside of the stratum corneum, which is also highlighted by the PAS as well as the GMS stain. Because the body has an inflammatory response to the fungal infection, usually you can see there is a neutrophilic crust in the stratum corneum associated with the hyphae form fungal organisms. There is a mnemonic. Try to remember the different disorder can have associated neutrophilic crust. The PTICSS is the mnemonic, including psoriasis, tinea, impetigo, candida, seborrheic dermatitis, and syphilis, which can help you make the differential diagnosis histologically. And also there are some body response, including spongiosis, vesicles. Those are not very characteristic. But the tinea, how can we subdivide them into different parts, different types? we subdivide them based on the anatomical location. As shown here, we have different terminologies. Tinea with capitis means scalp, corporis means body, etc. So those are the terms to describe different types of fungal infection. And you can see those are the clinical pictures. But basically, they have similar histologic changes, which is the hyphae-form fungus inside of the stratum corneum with a strong inflammatory response. There is a very interesting type of fungal infection, which is called Maiocchi's granuloma. The name has a granuloma, but in fact it is a fungal infection. And histologically, you can see there is a hair follicle. And when we zoom in, we see lots of spots inside of the hair shaft. And clinically, with this histologic change, you can have two types of disorder. If this is a hair follicle in the scalp, then the diagnosis should be tinea capitis, which is the tinea infection on the scalp. If this is infection in the non-scalp area, which is shown here, many folliculitis like little bumps in the hair covering area, which we call Maiocchi's granuloma. And the most common organism is the T. rubrum. Next disorder is called tinea versicolor. You can see in this dark-skinned patient, there are abundant numbers of the hypopigmented patches. And when we biopsy them, we will see there are two types of fungal form. First is the yeast, and the second is the hyphae. So the tinea versicolor is caused by the Malassezia furfur, which is a normal follicular flora in the skin when they are yeast form. When they start to overgrowth and start to grow like a hyphae form, then it becomes pathogenic. And it happens usually in the young patient. And the reason for the hypopigmentation is because the Malassezia furfur can interfere with the melanin synthesis. That is the reason causing the hypopigmentation. But in the light-skinned patient, there will be some hyperpigmentation due to the inflammatory. So that's why we have tinea versicolor. As the name implies, the discoloration can be variable. And I think the CP usually has a question, when we want to culture the Malassezia furfur, what should we do to let it grow better? Which is to add a drop of olive oil. I think the fourth years should know this. Let's move on to the candidiasis. This is also a superficial fungal infection caused by Candida. And you can see in the intertriginous area, such as under the bilateral breast, there is a very red irritated erythema. And when we biopsy them and with the PS stain, we can see there are a lot of pseudo hyphae or some hyphae form of the Candida. So the Candida is a normal flora in the mouth and the GI tract, and their form is the yeast form. When they start to have the pathological situation, this is the time they start to develop the pseudo hyphae, which is demonstrated here, as well as rare hyphae form. And the clinical presentation usually is a red plaque in the moist area, such as under the breast intertriginous area, as well as in the corner of the mouth. So clinically, we got a lot of biopsy from the lip or from the corner of the mouth, and they said this is verrucous lesion rule out squamous cell carcinoma. And when we stain with the PS, we see abundant Candida overgrowth. Then usually we say there is a pseudoepitheliomatous hyperplasia in association with the candidiasis, and we would recommend them to treat the candida first. And after the candida is cured, they need to rebiopsy if the lesion persists, because we don't want to diagnose a cancer definitively on the very inflamed and candida infected skin. So that is the caveat we need to remember, that candidiasis can cause the pseudoepitheliomatous hyperplasia, can mimic cancer. Another tip for the fourth years when you are taking the board exam. In the board exam, whenever they give you a picture looks like a squamous cell carcinoma, do not choose squamous cell carcinoma. Usually that's just a trap. There should be something else. Either it's an infection or maybe there is a granular cell tumor. But squamous cell carcinoma is never the right answer. They want to trick you. Remember that. Next disorder, clinically, they can represent a dark patch either on the palm or on the sole of this acral skin. And clinically, they resemble a pigmented lesion. Maybe the clinician is worried about the melanocytic neoplasm and give us a shave biopsy. And on the histologic evaluation, we see only gold to brown hyphae in the stratum corneum. And we know that is the reason causing this hyperpigmentation in the acral skin, which the name is the tinea nigra. And the common organism is the H. wernickeii. So that may be tested. And you can see there is pigmented hyphae in the stratum corneum. The yeast and the tinea we mentioned in the previous slides, they are not pigmented, and this is the pigmented one in the superficial fungal infection. There will be more pigmented in the deep tissue. And here comes the first pigmented fungal infection in the deep tissue, which is a chromomycosis. And from the clinical picture, it looks like there is active annular shaped lesion, which is highly suspicious for a fungal infection. And histologically, you can see there is a multinucleated germ cell, and inside the germ cell there are many round refractile organisms. And histologically, they resemble the copper pennies, so we call them copper penny body, or if we use a different terminology, we call medulla body. No matter what we call, when you see this organism, it is the chromomycosis. And this is another one can have very significant pseudoepitheliomatous hyperplasia and with pustule. So pay attention to the deep portion, especially in the granulomatous area. You may find some organisms. Do not call squamous cell carcinoma in your board exam. That's almost always the wrong answer. The next disorder is called pheohyphomycosis. From the clinical image, you can see in this person's bilateral lower extremity, there are numerous dermal nodules. Histologically, we can see there is a cyst composed of macrophages, and inside there are pigmented hyphae-form fungi. The patient is almost always immunocompromised. So the chromo and the pheohyphomycosis, we considered them as the same disorder, but on two ends of the same spectrum. And they are both due to the dermatiaceous or pigmented type of fungi. But because of patient's immune situation is different, if the patient has a strong immune response, they keep as a medulla body or copper penny. If the patient is immunocompromised, they start to grow like a hyphae and start to have the pheohyphomycosis. But they are the same organisms. Now let's move on to some more aggressive types of fungal infection. On the left, you can see this male gentleman is having many umbilicated lesions on the face. In the center, some of them are showing necrosis in the central area. Histologically, when you stain with the fungal stain such as GMS and the PAS, they are highlighted. One unique feature you can see here is the size of the organism. They vary a lot. Some of them look very small, some of them look very large. The GMS, the PAS is showing the same thing, some very large, some very small. Not only the size vary, but also there are two very special stains. They can highlight these microorganisms. One is the mucicarmin. Second is the Fontana Masson. The mucicarmin stain usually is the stain to highlight the mucin. Fontana Masson is a stain usually to highlight the melanin pigment. But those two are staining. And if you stain with a gram stain, you can see there is a capsule, and which can also use the Indian ink. At this moment, I hope you have already shouted out the organism's name, which is the Cryptococcus neoformans infection. The histologic features include the features I mentioned in the previous slide, including the size variability, which means the yeast are very pleomorphic. Also, they can stain with the Fontana Masson and the mucicarmin. Also, you can see the narrow-based budding yeast. Those are the features of the crypto. Next disorder is called coccidioidomycosis. This one has a very funny or very interesting morphology, and it has a very large, big bag, and it can be as large as 100 microns. And interestingly, inside of the bag, there are so many like marbles inside of the bag, which is we call endospores. Sometimes the outside bag, they can burst and release all the small balls into the tissue. So that is a very unique feature of this disorder. The wall is a refractile, so it is easily to differentiate this microorganism from other part of the deep fungal infection because of the unique large morphology. You will not miss this. Here I'm including a CP question. I remember this was a question asked by Dr. Love while I was at LSU. Dr. Love's question was, when you see this type of microorganism on your tissue slide, what should you tell the microlab? And the answer should be, if the patient has a concurrent tissue culture, ask the microlab, do not open the cover of the culture plate. The reason is the cocci can be very contagious, and when they open the lid, the microorganisms will spread into the entire lab and cause contamination. They need to do a lot of decontamination. It will very time consuming and very dangerous for the lab staff. So it's good to remember that. The next disorder is the blastomycosis. And the blastomycosis usually is a larger yeast with a size of 10 to 15 microns. And one very unique feature of the blasto is the broad-based budding yeast. It's easy to remember. Blasto, there is a B, and broad-based budding, there are 3 B's, B for B. And it has the refractile wall, but it is asymmetrical. Those are the features of the blasto. And one not too unique, but good to remember, is the blastomycosis can also cause the pseudoepitheliomatous hyperplasia, which can mimic a squamous cell carcinoma of the skin. Next disorder is the histoplasmosis, which is an infection caused by inhaling the spores of a fungus called Histoplasma capsulatum. And it usually infects the lungs, but also it can spread into other parts of the body, including the skin. And as the picture showing here, the patient is having those macro papular lesion on the trunk. Histologically, you can see within the histiocytes, there are numerous intracellular organisms with some pseudocapsule. And if you remember from the parasite chapters, those can have a very similar looking as the leishmaniasis. The leishmaniasis, if you read the books usually tell you there should be two features to tell the histoplasmosis from the leishmaniasis. One is the kinetoplast, which can only exist in the leishmaniasis. The second is the Marquis sign. What is the Marquis sign? Means there are lots of the light at the peripheral of the billboard. And here is the leishmaniasis. But in real life, sometimes you can see this feature in the histoplasmosis as well. And the kineto, if you don't have experience, if you don't have the 100x oil, that can be challenging as well. So the reliable test is the PCR to tell them apart. But just remember, the leishmaniasis and the histoplasmosis, both of them are intracellular and they can look very similar. Sometimes you can tell from the patient's travel history, but it's not as reliable. The histoplasmosis, they have a very small size, which is 2 to 4 microns. They are very small. This is the map we should be familiar with when we talk about the different geographic distribution of the fungal infections. If we are talking about the crypto, they are located on the west coast. And I think everybody knows that in the desert area, we should consider the cocci. And when we say the histoplasmosis, we are talking about the Ohio and the Mississippi River Valley. And when we talk about the blastomycosis, we are including the same location of the histoplasmosis, which is the Mississippi and Ohio River, but also include the Great Lake area. So those are the geographic locations. It's good to remember. And next one is paracoccidioides infection, which is more common in the Southern American area. And just one thing to remember, I think is enough, which is the narrow budding with a very unique mariner's wheel pattern. And I guess everybody knows about that. The next one is important for the Dermpath, which is the sporotrichosis. The classic clinical scenario is a person is a gardener and is cleaning the garden maybe in April, and start to have a rose penetrated his arm and start to have those bumps in the arms and causing abscess and granuloma. And when we have the biopsy, we can see the pellucidin granuloma with neutrophilic pus. And when we do the special stain for fungus, we can see there are some yeast, and interestingly, some yeast look like scar shape, as shown here and shown here. So the scar shape is a keyword for this disorder, sporotrichosis, in the gardener. So be careful when you are cleaning the trees or cleaning the plants in your garden. As a dermatopathology, we don't have many urgent situations. I can name a few of them, including Stevens-Johnson syndrome and calciphylaxis, and the third one, I guess, would be the deep fungal infection. And zygomycosis aspergillus, those could be the reason being called to the hospital to do the frozen evaluation. And the zygomycosis, the common scenario is the patient is severely diabetic and happen to have a leukemic or neutropenic. Then the patient have a fast-growing ulcer with a black necrotic eschar on the top. And clinically, they are suspicious for deep fungal infection. On the section, you will see those broad, hollow-appearing refractile hyphae at a 90-degree angle. And one very unique feature is the fungal is they can invade into the blood vessel and causing some infection and compromise the blood flow, causing the tissue necrosis. That is why it is so deadly aggressive. And from the microbiology, we know there are three major parts, including the mucor, rhizopas, and the abscidia. And how we tell them apart, when you reach your fourth year, you will remember them. The mucor does not have the roots. the rhizopas, there is a roots directly beneath the stalk, and the absidia, there are roots, but it's not corresponding to the stalk. That is how I remember it. And here is the histology, and actually those pictures were not taken by from the book. I took those pictures while I was at Tulane for my Dermpath fellowship. And you can see there is a very broad aseptic fungal hyphae, and some of them are folded into a 90-degree angle. And the PS is showing the same thing. You can see the 90-degree angle. However, I would like to point out the 90-degree angle thing is only should be only evaluated on the culture tissue. If in the human tissue, the morphology can be altered because the patient's immune system or the patient is using any anti-fungal therapy that can alter the morphology of the fungus. So evaluation on the tissue for the fungus is not reliable. So I strongly not recommend you to tell the clinician what type of fungus it is based on the tissue. You should only tell them it should be a deep fungal infection, but don't ID it until you have the culture result. Next one is the aspergillus, and aspergillus clinically looks similar. It's an ulcer with a black Ishar, and histologically you can see those narrow non-pigmented hyphae with the septate. You can see the septate here. Also, in the ideal environment, which means the culture plate, they should look 45-degree angle branching. But again, in the tissue, sometimes they don't follow this rule. Okay, let's quickly go through a few parasites. First one is the scabies. The scabies is the patient usually extremely pruritus, and the presence as papules, vesicles all over the body. And the most common location of involvement is between the fingers. And sometimes the clinician may do a biopsy, and you can see under the stratum corneum and above the cellular epidermis, there are organisms. And you can see the eggs or the mites and in the subcorneal zone. So this is a definitive diagnosis for the scabies. And next one is the mariasis. It's an infestation of the skin by the larva of the flies, which is nasty, but in the exam they may give you a picture of this and ask you what organism, what bug it is. And if you know it, you can choose the right answer, mariasis. Now, let's move on to some cute viral infection. The first one is the molluscum contagiosum. And remember a few things, including it is the family of the pox virus. And what are the name of those bodies? They call Henderson-Patterson body or molluscum bodies. I think that should be enough to make the diagnosis as well as dealing with your exam. Next is the herpes virus infection. The common ones including the HSV1, HSV2, and the VZV, aka the HHV8. And in the human body, usually the HSV1 infect anything above the umbilicus, and HSV2 usually infect the genitalia, which is below the umbilicus. However, nowadays people do some unusual things and can cause different types of infection. The VZV, which is the chickenpox or the zoster virus, also known as the human herpes virus 3. At this moment, I hope you can remember different types of HHV subtypes. The HHV4 should be EBV, 5 should be CMV, 6 should be the roseola, 7 should be the pityriasis rosacea, and HHV8 is the Kaposi sarcoma. So sometimes the exam will give you different names and you should be able to recognize them. And everybody knows that the herpes virus infection can have the 3M, which including the molding means the nuclei are crushed on top of each other, the multinucleation and the margination of the chromatin. You can see it looks ground glass and the chromatin are going to the periphery of the nucleus. Also, sometimes you can see the the leukocytoclastic vasculitis in the deep portion of the herpes virus. Those are the features. I believe everybody, after a few months of training now, should be able to recognize the herpes infection quite easily. Next is the human papillomavirus infection. I understand you should have already be very familiar with the histologic changes, including the hyperkeratosis, hypergranulosis, and the coilocytic changes. But I would like to point out it's better to remember what subtype of the HPV is associated with which variant of the HPV infection. For example, in the plantar HPV infection, the most common subtypes are 1 and 2. In the flatwort, which another name is verruca plana, is the HPV 3. In the condyloma, we are talking about a low-grade HPV infection. The most common ones are the 6 and 11. And the high-risk HPV, which can cause the cervical cancer, which is the 16, 18, 31, and 33. And there is another one called epidermal dysplasia verruciformis, which is HPV 5 or 8. I don't think that will be tested in your board exam. You should remember the 4 on the top. Now let's do a quick recap on the fungal infection. On the left is the buzzword, so-called buzzword, and on the right is the infection or the name of the disorder. I hope after today's lecture, no matter I'm telling you the one on the left or the one on the right, you can immediately tell me what is the corresponding one. So let's get started. When we talk about the stratum corneum with the hyphae, you should think tinea. When you see there are spores in the hair follicle, you should think either tinea capitis if that is on the scalp, or Maiocchi granuloma if that is on the trunk. When you see the spaghetti and the meatballs, you should think the tinea versicolor. When you see the pseudohyphae in the moist area, such as the armpit or under the breast or the corner of the mouth, you should think candidiasis. If you see the pigmented fungus in the palm or sole, you should think tinea nigra. If you see in the deep tissue there is pigmented hyphae, you should think pheohyphomycosis. If you see only spots in the deep tissue with pigmented spots, you should think chromo. If you see the yeast are very pleomorphic, vary in size and shape, you should think crypto. If you see there are small balls inside of the large bag, you should think cocci. If you see the small microorganisms inside the histiocytes, you should top two things should be histo and leishmaniasis. If you see the mariner's wheel, you should think paracoxy. If you see scar shape, you should think sporotrichosis. When you see broad hyphae with a 90-degree branch, you should think zygomycosis such as mucor or raspus. If you see narrow with a 45-degree septated fungus, you should think aspergillosis. So this should be a very important thing to remember for the fungal infection of the skin. Okay, we have successfully finished our cyst part, infections part, and let's talk about the food. Actually, I'm kidding. Let's talk about the paniculitis. Why I'm putting the cereals and the chicken soup, you will understand. What is paniculitis? Paniculitis is an inflammation of the adipose tissue. So that's why the adequate fat sampling is very important. Imagine this, if on the slide you only receive the superficial dermis, you will be no way, there is no way you can sign out the case correctly. The second one is getting a little deeper. You see, oh, there is vasculitis, but still you have no idea what is going on. Maybe you can give differential of the vasculitis, but you can only make the right diagnosis of panniculitis if you have the entire tissue to include the deep fat. So another trick is in your board exam or RES exam, if they are giving you a whole slide image, including so much fat, probably they are trying to test you on the panniculitis. So panniculitis, by definition, it means inflammation in the subcutaneous fat layer. It has a very broad spectrum of diseases. I can list maybe 15 different disorders, but for your residency training purposes, I think master the following 4 or 5 should be enough. To have a better understanding about the adipose tissue, I would like to use this image to demonstrate. This is the fat lobules, and this is the thin fibrous tissue. We call it septa. And the little blood vessel inside of the lobule is the artery, and the larger vein inside of the septa is the venous. So if there is a problem in the artery, then the entire tissue is ischemic, means the problem will affect both the septa as well as the lobule. But if the lobule is okay, but the septa is diminished, you will see still enough oxygen supply and blood supply in the lobules, and the pathology only affects the septa. So that is the general idea of the adipose tissue blood supply. And when we want to classify different types of panniculitis, usually we ask 4 major questions. First, is the problem in the septa or in the lobular? Second is, are they involving the large vessels? The third is, what type of inflammatory cells are there associated with the panniculitis? And the last one is there any particular history? Based on those 4 questions, we can basically give the different differential diagnosis. And those 4 major ones, I think, are enough for your residency as well as for your AP and CP board exam. Under the septal panniculitis category, the most important one is the erythema nodosum. In the lobular panniculitis, including the alpha-1 antitrypsin deficiency, erythema induratum, pancreatic panniculitis, and there should be lupus in the lobular panniculitis, but I would like to include that in the inflammatory next lecture. Next, let's talk about the biggest difference between the septal and the lobular panniculitis. In the septal panniculitis, which is on the left picture, you can see the lobules, they are intact. Those adipocytes, they look similar in size and the shape. And in the scanning power, you can see they are resemble the bowl of toasted oat cereal. So that's why I'm putting the picture of the oat cereal. On the right, it is the lobular panniculitis. You can see the lobules, they are necrotic. So those fat lipids, they just merged together. The lipophages are common, and the necrotic tissue, the lipids, they accumulate in pools with a varied size and shape. So that's why the low power, they resemble a bowl of the chicken soup. So that's why I put those 2 pictures on the first slide of this panniculitis. I hope that makes sense and help you to remember it. First, let's talk about the septal panniculitis with the example of the erythema nodosum. The common scenario is a middle-aged female with painful subcutaneous nodules without ulceration in the pretibial region. And when we have the biopsy, and even from the low power, you can see the fat lobules, they are mostly intact. The problem is the septal. Remember the very delicate thin septal in the healthy fat tissue. This one looks, the septal is very thickened. And also you can see different types of inflammatory cells infiltrate. In the acute phase, you can see neutrophils. In the chronic phase, you can see the granulomatous inflammation. There is a very unique type of granuloma, which will be shown in the next slide. Other than the septal panniculitis, Michel radiogranuloma is one of the characteristic features of the erythema nodosum. What is the Michel radiogranuloma? That by definition, it should have a central cleft as shown here, and at the periphery there should be aggregation of small histiocytes of variable shape as shown here. So when we have the septal panniculitis with inflammation and the Michel radiogranuloma, we can nail down the diagnosis of the erythema nodosum. Next disorder is under the category of lobular panniculitis, and the first one in this category is the pancreatic panniculitis. It is usually associated with pancreatic disorder, and more specifically the chronic or acute pancreatitis, but also it can be seen in the pancreatic adenocarcinoma. The physiology of this disorder basically is the lipase and the amylase from the pancreatic gland. They were pushed into the bloodstream, and in the fat lobules they cause the hydrolysis, and the hydrolysis is causing the necrosis of the fat lobules and form those calcium soap, or another term is called saponification. The necrotic lipocyte, when they died, they left over only those calcification, and we call them ghost cell. Don't be confused this ghost cell from the pilometricoma. They are both ghosts, but they are different cell of origin. You can also see there is mixed inflammation. This is the pancreatic panniculitis. There is another triad, which in your board exam, they like those triad or syndrome, those terminology. So I hope the fourth years can remember there is a Schmidt triad, including the fat necrosis, polyarthritis, and eosinophilia. If you see that triad, it usually means it has a poor prognosis. Next disorder is the erythema induratum, and some people use a different term as a nodular vasculitis based on the presence or absence of the tuberculosis. But I think they, in general, at your level, you can consider they are the same thing. And it's different from the erythema nodosum, which happens on the anterior pretibial region. And this one is a painful nodules on the calves, or the mostly calves, but they can be seen in the shin. And the erythema nodosum, they resolve without any scarring or ulceration. But this one, erythema induratum, they can resolve with scarring, and ulceration may occur and quite common. The etiology of the erythema induratum, including many types of infections, the most common one including Mycobacterium, Brucella, or Hep C. However, in the tissue, when you have the punch biopsy, most of the time when you perform the AFB or FITE test, it usually is negative. But the PCR, sometimes you can detect those tuberculosis mycobacteria. So that is something to remember. And histologically, it is septal panniculitis. As we mentioned, septal panniculitis means a bowl of chicken soup. And you can see there is chicken soup morphology of the lobular necrosis. Also, you can see the septal is also involved because the artery was damaged, causing this necrosis. Inflammatory cells, they can have the multinucleated giant cells and the neutrophilic infiltrate. And one unique feature of the induratum, erythema induratum, is there can be neutrophilic vasculitis involving the blood vessel. So that is a unique feature. That's why we have another terminology, erythema induratum / the nodular vasculitis. Next disorder in the lobular panniculitis is the alpha-1 antitrypsin deficiency. You can see from the image on the bilateral leg, there are numerous ulcerations, and some of the ulcer is oozing some oily discharge. And after they heal, there can be scar on the wound area. The patient does not only have the skin ulcers and discharge, but also they can have other clinical presentation in the systemic part, including the liver, lung, and the pancreas. There is one important thing for board purposes is the alpha-1 antitrypsin deficiency. They can have different alleles. More specifically, if the patient has allele as M, means it is a medium, means normal quantities of enzyme. In the S is the slow, means decreased but moderate. Z means very slow, means it decreased the quantity of enzyme and is severe. Because of that combination, if the patient is PIZZ, that means the patient is the most severe phenotype. I think the board and the RICE exam likes to test this point. Histologically, the alpha-1 antitrypsin deficiency, it is a lobular panniculitis, and you can see there is also liquefactive necrosis as well, and the neutrophilic infiltrate in the septa as well as in the lobules is an important feature, but it's not unique. In order to make the different diagnosis of alpha-1 antitrypsin deficiency, usually they need to give you more clinical scenario of the systemic involvement in the lung, pancreas, and the liver. Last but not least, there is a type of disorder commonly seen, but it can be a mimicker for panniculitis. It is a traumatic fat necrosis. As the picture shown here, you can see this area, maybe it has some trauma before, and the tissue, we are very familiar with fat necrosis, with the large and small lobules with histiocytes. But if they only give you one portion without the clinical history, you may be confused this one with the panniculitis. So the history of the trauma is the key. And in the fat necrosis, if it is resolved and encapsulated by those septa or fibrous tissue, it can form an indurating nodule. Then we call this encapsulated lipoma with necrosis. But no matter what, it is a benign. Other common location other than the regular trunk which can have trauma is the female breast, which can be traumatized by kick by the kid or by the steering wheel while driving. Now we are reaching the end of the panniculitis. Let's do a quick summary of the panniculitis, also key points and the disorder. The key points, if we see only septal panniculitis with the Michel granuloma, what should we think? We should think the erythema nodosum. If we see those calcified ghost cells, what should we think? We should think the pancreatic panniculitis. If we see both lobular and septal panniculitis with vasculitis, we should think erythema induratum. If we see lobular septal panniculitis plus systemic involvement, we should think alpha-1 antitrypsin deficiency. Those are the most important differential diagnoses. Okay, today we talked about the different types of skin cysts. Then we discussed about the skin infection, including the skin fungal infection. And lastly, we discussed about the different types of panniculitis. I hope the lecture will be helpful, and I look forward to seeing you in the next lecture. Have a nice day. Bye bye.